patient safety research collaboration seminar. This is a seminar that we host on behalf of the entire Safety Net, which is the group of patient safety research collaborations across England who come together to form the Safety Net, and we run a series of seminars on behalf of that group. And really excited today to have Peter with us, Professor Peter Hibbert. Peter has stayed up very late to deliver this seminar, so I'm glad there's a really good audience here for him. It's 9:30 in Australia at the moment, where Peter is based, and Peter's based at the Australian Institute of Health Innovation. Peter's worked for the last 20 years in both research and policy implementation in patient safety and the measurement of evidence-based care. And before that, Peter's actually based at the UK, in the UK, as Associate Director at the National Patient Safety Agency here before it was disbanded. I'm sure that was nothing to do with Peter. Peter, as well as doing research and having a very illustrious research career, really gets hands-on in terms of his training and leadership around how to conduct investigations. And you'll notice if you've read his bio that he's trained over 7,000 healthcare senior executives, managers and clinicians around how to do good investigations. I'm really excited to hear from Peter today about work that is currently ongoing within the Australian Institute of Health Innovation that he's leading around improving the response to adverse events. So without further ado, thank you so much for joining us today, Peter, and we look forward to hearing your talk.
Thanks, Rebecca. I really appreciate the invitation from yourself and Will, and really looking forward to talking with you all and having a conversation at the end. So my talk is on improving the response to adverse events, research and innovations from Australia, and also just to say, you know, we've had a few people cross paths between our two institutes. Natalie Taylor was at AIHI for a while. Rima Harrison is with us. So, you know, it's fantastic to have those. It's fantastic to have those connections between the two groups. So just a little bit about the Australian Institute of Health Innovation. Our goal is to co-create high-impact health services and systems research that drives positive change in policy, practice and behaviour for the benefit of all. We're based at Macquarie University in Sydney. We're the largest health services research institute in Australia. We're led by some names you probably are aware of: Professor Jeffrey Braithwaite, Joanna Westbrook, Enrico Cuera and Henry Cutler, who's our newest director, leads a group around health economics. We do lots of things, and you know, very much like the Yorkshire group, we've got a really wide and eclectic research expertise and interest, and there's about 100 staff, and we have a network of about 250, 300 people. So really proud to be there and be a small part of the great work that we do at AIHI. Okay, I'm going to talk to you about a grant that I'm leading at the moment, which is a National Health and Medical Research, or NHMRC, partnership grant. NHMRC is like your NIHR equivalent, so it's the national body for medical research. It's called a partnership grant, so there's financial partners that I'll talk about a little bit later, but Safe Care Victoria, the New South Wales Clinical Excellence Commission, Clinical Excellence Queensland and ACT Health. So these are 4 states and territories in Australia. The Australian Commission on Safety and Quality in Healthcare is a non-financial partner. We've got 4 years funding to do this work, and it's actually born from a common frustration of adverse events continuing to occur despite significant investigations and reviews. quickly going to go through really just to show you some names and just to really remind myself and you that the best work in research is really done by teams and by people with different expertise. So these are our fantastic group of chief investigators from Macquarie University and other universities across Australia. We've got associate investigators. We've got key contacts at our partner organisations. We've got a fantastic consumer governance group. They just help us out amazingly, and we've got a fantastic research team. So together, this group are responsible for what I'm presenting to you today. I think we're well aware of the problem. This is from Maria's paper. We're looking at hospital admissions associated with harm, about 12% or 1 in 8, and then about 1 in 16 hospital admissions there is preventable harm to patients. And when you've been around the safety world for as long as myself and Rebecca have been, you see these figures time and time again over the last 20 years. So they haven't shifted a lot. Healthcare's got more complex, and our expectations around the health system have changed, but there's still these figures that, particularly preventable harm ones, that we still need to work at and to try and improve. One of the ways, when there's a serious adverse event, one of the key way actually that health services try and reduce harm to patients is to undertake an investigation. So they pull a team together within the health service, and their 3 questions are, what happened, why it happened, how can we stop it happening again? There's a team together, and there's these set of processes and methodologies and data sources that they work through, that's illustrated on the right, with culminates in developing recommendations and actions to try and reduce harm, and then trying to implement those recommendations. There's different sort of methodologies for these investigations, and you might be familiar with some of these names: root cause analysis, London Protocol, Axiom-App, SEEPS, and there's more. But actually, when you look at the different methodologies, the process is reasonably similar. Okay, about setting that team up and undertaking data collection analysis specific to the event. Do these investigations actually result in reduced harm to patients? There's not a lot of studies out there, but there's been 3 systematic reviews on RCAs, and most studies don't report improvements to patient care. There are some problems with the study designs. They're mainly before and after study designs. And many of the endpoints of the study are around attitudes and knowledge. They're the most common hard points, so they're not necessarily clinical hard points. So it's actually quite a difficult area to research, because there's so many levels in the system that actually impact on the effectiveness of an investigation. So the research is difficult in this area, but it seems to be pointing to we haven't really found great results in terms of undertaking these investigations, hence the need to do this work. This is a reminder to myself and everyone else that, although our research is really focused on undertaking investigations, which is to tackle the first point, which is to prevent the same incident occurring again, but organisations have other obligations when there's a serious adverse events, really serious obligations, and that are important, and actually overlap with the investigation side of things and are subject of research as well. So open disclosure to patients and families, really important, or statutory duty of candour. Supporting traumatised patients, families and staff, remembering that a serious adverse event can be the worst thing that happens to someone in their career. Restorative just culture to everyone who's been impacted. There needs to be assurance to CEO, the board, and the minister that the problem needs to be addressed. Critically, when investigations are occurring, it's not just the opportunity to obviously try and prevent the same incident occurring again, but it's around modeling a safe and just culture. So it's fairly easy to put in your policy and procedure about that we do have a safe and just culture, but when there's a serious adverse event actually occurs, then that's when organisations are really tested. So, and how the staff are supported, and how they're led through that investigation process, and the patients and families really is indicative of whether you do have a safe and just culture. So it's just a reminder that the response to serious adverse events is broader than investigations. Okay, back to this research that we're doing. So we are trying to improve the health system's response when patients are harmed based on our partnership grant. Our partners are on the east coast of Australia, so you can see those states and territories there. They comprise 79% of the Australian population, so a bit over 20 million people. In the public health services, there's 5.5 million hospital admissions every year. There's over 500,000 patient safety incidents reported, and about 1,000 serious adverse event investigations occurring in those states and territories. So from a lots of incidents, and from an investment perspective, 1,000 serious adverse events is significant. Just a reminder that things work a little bit differently in Australia. So at the federal level, so at the Australian level, the Australian government has responsibility. These are very selected responsibilities, just to make a point. The Australian government has responsibility for regulation of drugs and equipment, so very much an MHRA kind of role. That they're responsible for regulation of hospital safety and quality standards, very much a CQC role. Development of quality standards. Really, they took that idea from NICE. How we fund hospitals, that federal level, and then also primary care policy and funding is at federal level. At the state and territory level, the operational management and planning of hospitals is done, and this is really important. So incident management systems and policies are developed at each state and territory. Okay, so, and even things like protocols and processes for things like deterioration response and recognition and response systems are done at state level. So if we think about the incident management systems, each state has their own incident management system across the whole state. They all use actually DATEX, so a version of DATEX, but they have their own rules around which investigation methodologies they use, how long you've got to do the investigation, who can do it, the sorts of harm scales that they use to decide what sort of investigation. So it means across the country there's the disadvantage is there's not that standardization across those incident management systems, but also means there's some innovation. And I'm going to talk about just two ideas that have come out from the States today. All right, so the grant that we're doing is that we're investigating at the moment. It's got 3 aims, and I'm going to work through each of these aims. We're about 40% through this grant, so I'm going to be giving you sort of early methodologies and some of the work that's come out of this grant, but I won't be giving you final results. But hopefully, we'll give you some sort of interesting things to think about if you're working in this area. I'm going to go through each one of these aims briefly. So the first aim is really looking at how we can improve our response to serious incidents, really looking at that investigation side of things. The second aim is trying to utilize some artificial intelligence tools to improve our response and our analysis of not just lower harm incidents, but all incidents. The third aim is to undertake a cost analysis of the incident management system process. All right, I'm actually going to go through them backwards. So I'm going to test your ability to count backwards from 3. So I'll do the short aims first. So the first thing is we want to undertake a cost analysis of the incident management process. Why are we doing this? Well, we don't know the staff costs of reporting, managing, and analysing incidents. We do know it's significant. We don't understand the value of incident management systems as well. We are not going to delve into value. It's a really difficult question. So we thought we'd try and knock off the cost side of things first, and then we'll talk about value. The way we're going about this is we've got a set of focus groups that we have already undertaken, and essentially we activity map the process. We're just using two levels of incidents: serious incidents and lower harm incidents. We're not going to do 4 or 5. It's a bit too difficult. So typical serious incidents, typical lower harm incidents. What's the process? We model each step, and then try and work out with our focus group participants who work at health services the time each step takes, the level of number of staff involved, and then we multiply that up by the number of incidents per year. So you can see this here. We do a workflow map of the incident management process, both of serious incidents and non-serious incidents. We get the pay grades and scales, and support costs as well. We estimate the time taken for each process, and we do a sensitivity analysis. And then for each step of that process, we hopefully will be able to model that out. You won't be able to read this, and that's done deliberately. This is just one of the activity maps that we've come up with from one of the focus groups around the serious incident methodology or set of steps that are taken. And what's readily apparent just looking at this is the number of steps that are involved and how complex it is. It was really interesting with the focus groups that we had with, very experienced safety and quality staff who had never really mapped it out like this, and they were really surprised as to how many steps there were there and how complex the process had actually come. They were, some ways they were a little bit of shock on their face when they were doing this. So it was just from that feedback perspective, it was a really interesting and useful process for them to be involved in. They were really appreciative of it. So our next steps are to consolidate all these process maps that we're doing and start putting some figures against each one of those steps and then aggregating all that up. So that's where we're currently in the middle of doing that. Okay, aim 2, using artificial intelligence tools to help us analyze incidents. We developed this grant just at the time that ChatGPT came into the world. And the world's changed a lot since then. So we've had to sort of modify our methodology somewhat. We've just got the data that we're doing with aim 2, we're using with aim 2, and we've just started analyzing using our methodology. So the problem that we're trying to solve here is that we've got about 700,000 incidents reported in the public health systems in Australia every year. Those incidents mainly comprise of free text fields, and when I feel this because I've worked at the National Patient Safety Agency. At that time, we were getting 1.2 million incidents a year. It's something like 2 million coming into what is NHS England at the moment. But analysis and learning relies on reviews by human experts. Clearly, it's highly labor intensive and time consuming. So our question is, can we use large language models such as ChatGPT to assist in the analysis and learning of all those incidents? We've done all the ethics and set up the computing infrastructure. That took a long time to do that. And essentially now we've got 900,000 incidents from one of the states, all those from Queensland. We've got those incidents over 5 years, and we've got some data people to be running some large language models on those incidents and seeing if we can, if those large language models can assist in the analysis and learning of those incidents. I'm really keen to make this research practical. So, and not just, doing esoteric tasks. So, this is a diagram from a paper that myself and some colleagues from the MPSA and some other national bodies wrote a few years ago, 2015, 10 years ago. And what we're trying to do is illustrate essentially the process we were using at the MPSA to sense make thousands, hundreds of thousands, millions of incidents that were coming in every year. So we would, first of all, undertake surveillance manually. We would identify a trigger incident that was interesting. We would go back to the database and collect similar incidents, pull all those incidents together, characterize them, okay, looking at what their contributing factors are and the contextual factors, and then identify preventative and corrective strategies, and then in preparation to put out an alert. Okay, so what we're trying to do, get to a point where we're trying to say to ourselves, which areas can AI assist? It can't take over. What can assist? So we think it can readily assist in collecting those like incidents and characterizing them, and then possibly the next step will be to whether it can assist that surveillance task as well. So, but we're starting with the collection of incidents and characterization of the relevant incident types. So we had a meeting about this morning. We were trawling through the data, and we had a large language model tucking into the data this week. So that's really exciting for us to see how that work evolves over the next 6 months. All right. This aim one, what we're trying to do in aim one is to try and improve the methodologies and the way we tackle undertaking investigations for serious incidents. There's a protocol. We've published a protocol for aim one. So there's the protocol there. There's a QR code for it. Okay, I think this is a really important slide. We've got lots of research questions actually, so for aim one, but we really wanted to contextualize it into 3 big research questions. And the reason that this is important is that much of the safety science papers, when they're looking at investigation methodologies, focus on question 2. So that's really the safety science of undertaking investigations. So looking at different methodologies, so SEEPs and AXIMAPs and those sorts of things. And that's a really important question. But we really wanted to think about it broader in healthcare. So we really wanted to think about what's the best thing to do prior to the investigation? How should we decide what to investigate? How do we maximize learning? What's the best use of limited resources available? So, and I think that's a really legitimate research question. And then after the investigation, we all know that often where the issue falls down is that we might, the investigation might be quite robust, but the implementation of those recommendations or those actions may not actually reduce harm, or those recommendations actually may not get implemented as intended. So there's actually not a lot of research in this area about that. So we really think it needs to be we need to think about it broader than just the safety science part of the methodology of the investigation. This is our methodology. We've got multi-methods, multi-stages. We're undertaking literature reviews, document reviews. But the interesting things I want to talk about today are we're reviewing the quality of 300 investigations, and we're doing lots and lots of consultations with consumers, healthcare staff, and experts as well. We've done all that. We're now writing up those papers. Then the next stages are to develop best practice guidelines, and we want to do some small scale feasibility testing of essentially a re-engineered process. Okay, I want to talk to you about two of the things that have come out of the interviews and focus groups around innovations in two states, I'm just going to mention them quickly, and they might be points for discussion when that time comes. So one of the innovations in New South Wales is dedicated family contact that they've put into policy. Many hospitals do this informally. I think many of your trusts will do this informally, but this is actually a formal role that all the New South Wales hospitals have put in place. It's like a patient navigator role for a complex condition like cancer. So it's essentially a primary staff contact who's the point person who provides continuity for patients and families during a serious adverse event review and beyond. They establish rapport, credibility, and trust. They talk to the patient, talk to the family and patient about how they want to be communicated with, and really trying to understand their concerns. There's lots of practical assistance around that the families need, and liaising with the different teams involved in these serious adverse events. From the consumers that we've spoken to in New South Wales, they've been very positive about this process. It's a difficult job, but yeah, they've been very positive about it. So, and that's something that we'll be exploring a bit more in our papers. So, it's an interesting role that's developed. And the other interesting role is in Victoria. Then, since in the last 5 years, they've been putting consumer representatives on investigation teams. So these are consumers who have been trained up in human factors and investigation methodologies. They are independent of the family involved, or the patient and family involved in the incident, and their role is to bring the consumer's perspective to that investigation team, to provide an independent view, to advocate for the patient to remain central to that review process, challenge assumptions, etc. We've undertaken a qualitative study on the perspectives and experiences of these consumer representatives and the clinicians and the safety and quality people who are on the teams when consumer representatives are on them. So we've had that paper accepted in Health Expectations. So we're hoping that'll be published in the next month. I want to briefly talk about our investigation reviews. So this is where we're looking at undertaking quality assessments of investigation reports. So we've done this. We've already coded 300 investigation reports. Again, we're writing this up. We've coded those reports using the ICPS, so essentially incident type. We've used a tool from the Netherlands, which I'll explain in a moment, another tool from the NHS, and then we've developed an AXIMAPS and SEEPS coding framework to code the contributing factors, and then we're repeating we're repeating work that we've already done to look at the effectiveness of recommendations as well. This is the coding for the 300 incidents within those investigations. About half of them are around clinical process and procedure. About a sixth of them are around diagnosis assessment, and a little bit less around procedure, treatment, intervention. Falls 15%, behaviour 10%, which is mainly, but not exclusively, around suicides or attempted suicides. So no surprises there. So some of the investigation review tools. So these are essentially the NHS Learning and Improvement tool's got 8 questions, and ask questions such as, is a systems approach applied? Is human error considered a symptom of a system problem? Is blame language avoided? Is locum rationality considered? Is the report clear, easy to understand, and anonymised? There's lots of judgment in this. The IGZ, does the description of the event give a complete picture of the relevant scenes? Do the contributing factors fit the reconstruction and analysis? Do the corrective actions address the identified contributing factors, etc.? So we've had human factors experts using these 2 tools. There's a lot of quality assurance that's required when you're doing this. It's quite a complex task. And just to show some of the methodology, so in blue are the various bits of what's in a report. So you've got a narrative about what's happened and why in a report. So, you know, lots of text. You've got diagrams, such as cause and effect diagrams. You've got contributing factors and findings. So you've got explicit statements of what went wrong, and then recommendations. And this is just, I'm not going to go through this in detail, but with our people who are classifying it, we're just trying to illustrate to them where in the report that you'll find the various details of these questions. And we're really looking for what I call the red thread. So, you know, if you look at a recommendation, you can work back in the report to the recommendation makes sense if you look at the contributing factors, and the contributing factors you can see come out of the report. So it all should be that red thread should be clear. You know, for example, I know, so one of the examples where in the narrative one of the reports mentioned that a nurse was fatigued, but that didn't then express itself in the contributing factors. So there was a disconnect there. So that's why question 13 down the bottom, do the contributing factors fit the reconstruction and analysis? Difficult questions to you know, from a quality assurance and research perspective. Here's another really interesting example around Paul Bowie's tool. So and one of the questions is local rationality taken into account? This is an actual example from a report. So upon arrival, the consumer met the clinical criteria for sepsis. While this was recognised in the emergency department, the use of the sepsis pathway to guide practice was not adopted, and the care did not align to the health services adult sepsis pathway. And you can see that's, you know, reasonable statement. It's probably true, but we think it just doesn't go far enough. And for us, we don't understand what made sense to the staff at the time, what were their goals, understanding of the situation and focus of attention. So there's another why question there about why that patient wasn't put on the sepsis pathway, and what were the circumstances that allowed that to happen, and what can we learn from that? And for me, one of the big things that's really missing from a lot of these reports is observations of real work, and I think this is a nice illustration of that. We're nearly finished. We've also coded contributing factors and lessons learned and recommendations from the 300 reports. So we've got about 900 contributing factors, and they can have more than one classification. I'll show you the SEEPS classification, combination SEEPS axis maps in the next slide. And then we've had about 1,000 recommendations that have been classified as well. We're almost finalized that paper, but I won't show you results. I'll just show you this is a simplified version of the contributing factor classification from SEEPS, and it's actually SEEPS combined of SEEPS AxiMap as well. So we really wanted to get the levels involved. There's more levels than what we've showed you, but what we're really focused on here is, were most of the contributing factors at the level of the staff and the care team? Were there any contributing factors that were recognised at organisational level and external factors? Actually, the results are that almost half are at the level of the care team, staff factors, and patient and family, about 47%. So, so we still think that those investigations are probably not getting system level enough. We've also then classified the recommendations in strong, medium, and weak in terms of their effectiveness and sustainability, and we'll be linking up the contributing factors and the recommendations as well. We're doing secondary work. We're doing more classification. So we're actually using this classification to classify the recommendations as well, using a technique called Preventi Maps, and then we'll be able to directly link it. And we're also doing a deep dive of some other of the recommendations. So so there's more work to be done. So this is really exciting for us to not just look at this recommendations, which we've done previously, but also look at the contributing factors as well, because As I said before, when I mentioned that red thread, there's a lot of focus on recommendations, but it's a bit like treating a patient. So the treatment of a patient is really dependent on the diagnosis of the patient. The diagnosis of the patient is really dependent on the investigations and the assessment of the patient. So it's that red thread is really important. So where those recommendations come from should be from the contributing factors, which should be from the robustness of the actual investigation itself. Last slide, Rebecca. Where we want to get to is feasibility testing to re-engineer the investigation process, and these are the areas that we're looking at to re-engineer. As our results have started to come in, we've spoken to our partners and our academic colleagues with the question to say, with the feasibility study, should we focus on one area or should we try and re-engineer the whole process? And it's a bit of a trick question because I was thinking we should re-engineer the whole process, and pretty well everyone's agreed, mainly because like healthcare is complex, so is the process for investigating incidents is complex as well. And just changing one thing is probably not going to change the outcome. Okay, so just changing one little process is probably not going to change the outcome. We need to look at this from a big systems perspective, and so these are some of the directions we're going. Thinking about when to do an investigation, not just basing it on severity, but including learning and preventability. We should be doing less investigations, more aggregated reviews. Think about safety in big themes, not individual incidents. And this is the takeaway from that. We should be thinking about investigations as a tactic when there's a serious adverse event, and not just at the moment, it's kind of the strategy, it's the go-to. It should be one of the tools that we've got. Quality of investigations, professionalisation, independence. I think the third point is critical, more observations of real work. A lot of the safety science focuses on, the systems models, but actually I think that more observations of real work is important. And then this last bit, which is really about the implementation of those recommendations. Tricky area, but I think we need to integrate a lot of the fantastic skills that we have in quality improvement and implementation science into that implementation of recommendation side of things. That's it.
Thank you so much, Peter.
Happy for questions.
Yes, we've already got quite a few in the chat, but I just wanted to start by saying thank you so much for a really fantastic presentation at a particular point in a research study, which is, the exciting developing the methods, getting those early findings. But we'd love to have you back if you might be willing when you've completed the study and you've got those findings to share with us, because seeing it now and then seeing it later will be absolutely fantastic. So if there's any opportunity for that, and a couple of people have mentioned that in the chat too. So thank you very much. We've got some questions already, but I would imagine others will pop up as we go. So I'm going to come to Farhad first. Farhad, do you want me to read the question out, or you're just happy to ask it? Go for it. Oh, we can't actually hear you, so maybe I will have to see if we can.
Can you guys hear me now?
We can, thank you.
Perfect. Sorry, I'm in between two meetings. Peter, great presentation. So my question related to what's going on in other safety critical industries and whether you've captured that in your reviews or maybe as part of your primary methodology. Quite clearly, particularly in the UK, we've now got some new roles that are starting to come through in the safety space within NHS organisations. Patient safety specialists being one, patient safety partners being the other. And at the moment, alongside Graham Martin and Jane O'Hara, who used to be with Rebecca in Leeds, we are starting a study looking at evaluating those new roles. And I'm cheating a bit here because I'm asking you if you've done part of the work that I'm about to start doing. Have you looked at the evidence from other safety critical industries to see whether there is potential new roles that are already embedded within the investigative process that would be beneficial for healthcare to have a look at? And you've alluded to consumer representatives here, but these are very much models that are embedded within healthcare. But how about in other safety critical industries? I'm not limiting my question here to beneficial roles, but also beneficial models. So how are they approaching the investigative process differently, and what can we learn from them?
Yeah, and look, we have looked into bodies such as the ATSIB, you know, which is the Australian Transport Safety Investigation Body, and they some of the work that they've done is around methodologies that we will incorporate into this feasibility study. So we'll be consulting with them as we roll out that feasibility study. And as you say, it's not just about roles, but it is about methodologies. And I think the key thing that maybe that HSSIB in the UK or England has one of the things that we want to incorporate is that notion of independence. So, and I think that's really important that we strengthen that, and I think we can really learn that from those other safety critical industries, because I think much of the teams at the moment, I think, are really hamstrung by the organisations in which they're working. I think the other thing that we can really learn from those bodies is around the professionalisation of the investigator teams. You know, it's not just a side role for clinicians. It's actually a role in its own right. And I think those sort of notions are probably the most important thing for me. So it's really around some of the methodologies, it's around independence, and I think the professionalisation of the investigators. There's also just the way they don't just rely on things. I've already alluded to this. They don't just rely on mainly interviews, you know, and looking at the clinical notes. They take a much wider view of what are legitimate data sources to use for investigations, and I don't think we do enough of that in healthcare. I really like your work, Farhad. It's great.
Thank you. Hopefully we'll get to work together at some point.
Great. And these seminars are a great way for people to meet each other that they're familiar with in the field. So that's brilliant. I'm going to take Chair's prerogative now, because Livy has posted a question that is very similar to the one that I was going to ask. So Livy, I'm going to come to you. It's a long question, so you might want to just summarise to start with and then explore a few of the points that you're making there. Over to you.
Hi, can you hear me?
Yeah.
Yeah, fabulous. So thank you so much for such an interesting presentation and the work that you're doing. So I'm really interested in safety equity. And one of the things that I've been looking into is kind of the development of these safety science frameworks, such as the contributory factors frameworks, like the Yorkshire contributory factors, the London protocols, and trying to understand how equity is present within either the development of that or how it has been applied or implemented within research work. So how I guess equity is embedded within some of these kind of frameworks. And I was just, as you were talking, I was really interested in, because we know in the NHS that there are disparities that exist within the workforce, disciplinary disparities. We know that in the investigation workforce are particular types of people that are band 8 and above. And we know about the snowy white peaks with Roger Klein describing who is in positions of power that exist within the NHS. And I was just wondering whether those dynamics exist within the Australian context, and who might be disproportionately affected by safety or adverse events that might be occurring within these hospitals, and how that might have been incorporated into your thinking with the research that you're doing currently. So yeah, I guess I was trying to really understand whether, if contributory factors frameworks have been developed without equity in mind, if you're looking at investigations that have already been done, are we kind of just doing a bit of a chicken and egg situation? And whether in those, did you say 900 contributory factors, whether any things that came up that weren't necessarily found within previous empirical frameworks that have been developed? I hope that's in a nutshell.
Yeah. So, you know, from the adverse events perspective, there's been similar research from our group actually, and from actually Rima, who used to be who worked with Rebecca, that has shown that there are inequities in terms of the people who suffer adverse events. So as a first thing, so so people in minority groups are more likely to suffer adverse events. I don't think that that we've quite captured that in the work that we've done at the moment at the level that we've done it, but we've only really gone high level at this stage. So, and there's a lot more questions. There's a lot more questions to ask. So about these about the adverse events and the investigation methodologies that that we are using, and particularly, as you say, around the contributory factors that, you know, are those power imbalances not just from a staff perspective, but from a patient perspective? Are we actually capturing those? And I don't think we are. Yeah, so I think it's a really good, not just question but comment. Yeah, and I think it's something we could probably look into a bit more into a bit more detail.
Thank you,
So
Peter.
thank you.
Thank you, Peter. Maybe I'll probably be coming back to you at some point to further comments around that, if that's okay.
Yeah.
Okay, so we'll move back up now to Will's question, and Will's not so good today, so he's asked me to read this out.
Yes. I've got it.
So Will says, I've often found it difficult to explicitly define or measure investigation quality. You mentioned some tools you used when reviewing the 300 incidents. How did you find using them?
Yeah, look, we struggled. So you know, I showed you that you know, schematic about how we interpret it. There's a lot of interpretation that's required from, and we had a team of people, so we had weekly meetings, and we would present a case each week. We had a detailed set of business rules that we developed and then had to continue to develop. I suppose it's deductive. It is deductive, but there's so much judgment involved, and we really struggled with the task. And I'll be really explicit about that. I think for some of the IGZ we modified because we found that some of the questions just didn't quite work. And remember, this is artifact. This is also artifact research, so you really can't get into the head of what was going on at the time. So, which is a massive disadvantage. You've only got this artifact, and it's only as good as what they've chosen to put down on paper. So, and it's only as good as it this artifact has gone from the team. It's often gone up into the organization. It may have been modified somewhat. So you lose all that. I'd love to see the drafts, and see how they change over time. So yeah, we struggled, and I think we basically tried to answer all the questions in these tools, but again, if we did it next time, we would cut it down. So, and just try and get to some of the core issues that we feel are the most important ones. And we actually added one in, which is that really crucial one that I was talking about before, is did they use observations of real work or simulations or those sorts of things? That wasn't asked in the tools, but we added it in. And spoiler alert, of the 300, we could only see evidence of a handful of the investigations actually use that observation of real work to inform their findings. And I think that's crucial.
We've got 2 more questions that I'm going to try to ask within the next few minutes left. And the first one is from Tracy, because I'm at the bottom at the moment, and then I'm going to skip back up to Richard Kears. So Tracy, do you want to say your question out loud?
Can you hear me okay?
We can, thank you.
Oh, great. Sorry. Yeah, thanks, Peter, for a great presentation. I was just wondering if you had any kind of early insights into how to factor in learning potential into decisions around when to investigate. This is something, I guess, that we've tried to build into PSEF, but reviewing a lot of organizational plans and how they're prioritizing their resources and what they're investigating. A lot still tend to focus on harm as a threshold for investigation. So yeah, just interested in if you've come across anything useful as part of your research so far.
Yeah, and look, I think we can put some sort of criteria in, as a step, but I think also we're looking at learning from you guys, because some of these ideas have really been facilitated by the work that's happening over in the UK, because you're facing similar issues to what we are. But I think it is a combination of severity. Clearly, it's a combination of severity, frequency, how much we know about this problem already. Falls in the elderly, we know a lot about, and they happen frequently. So that's that potential for learning thing. Preventability, we've had a lot of pushback from the policy people about preventability, because it's easy to go down a rabbit hole with that. But I think it's this clinical. I think it's a mix of those criteria. But then the next thing is, I think we need a process for decision making. So some senior people thrashing out those sorts of criteria, because it's not I don't think you can make it into an algorithm. And I think that's what we learned when we're at the MPSA, and we had 300 serious incidents coming in every week, and we'd have clinical staff go through each one of those incidents, bring it to a meeting, bring a set of incidents to a meeting that every week that they found that had potential for national learning. And we would thrash that out as a group. And what I learned from that is, the criteria is not an algorithm. It's a mix of those different criteria and clinical acumen around the best use of that time. I think we need to spell out those criteria a bit better than what I've explained. But I think it's that expert decision making needs to be facilitated as well.
Thank you. It's not an easy area, is it? But like you say, something where some consensus at senior level might be really appropriate, and involving patients as well in that discussion.
Yeah, that's right.
Okay, so Richard Kears, if you'd like to ask Peter a question now. Thank you.
Thank you, Rebecca, and excellent presentation, Peter, really thought-provoking. And my question was about, I guess, something I've seen quite a lot in practice, which is the recommendations. And I noticed you'd started to structure them based on strength, and you were talking about implementation at the end being an area of importance. One thing I found is they're often quite rushed as part of the investigation process. It's the end, people are kind of trying to wrap things up, things might have overrun, and it's not really done right, at least a lot of the time. And I just wondered, particularly from the point of view of generating recommendations and meaningful recommendations, what's been your experience generally, but also in this study, and what do you think needs to happen potentially in the future, jumping the gun a bit, in terms of this arguably the most important part of the whole process, which is turning what you've learned into something that's going to be meaningful and lead to change?
So I agree with you that it's rushed, and sessions I was within a couple of weeks ago was the first thing I said is you need separate time for this, and you need dedicated time. Once you've developed up whatever your contributing factors look like, you need to take a step aside. In actually one of the states in Australia is getting a separate team in at that point. So, the first team get up to the contributing factors, and then the next team take over, and then they do development and implementation of recommendations. So it's an interesting model. We haven't quite worked out whether it's an improvement, but it's interesting. But I think that also getting people involved from the clinical area where it occurred. I think also looking at what other organisations are doing, both from a people-to-people perspective, but also looking what's out there in the literature. We know that organisations are not doing it. We saw in our study they're just not looking out. But I think they're staying within their small team of 4 or 5 people. They're not going to the clinical teams where this incident occurred and saying, these are the contributing factors. What are the ideas that you can generate from from the ground? But they're not also looking up and out either. So, and I think that combination needs to be done. I also think they need to be, there's a few models around about how you can risk rate recommendations in terms of how effective they are, and we use one model. There's a few of those tools around, but I also think the recommendations should not just be looked at individually, but how they work together as a group. And then the other thing, I just wonder whether we should be making recommendations based on individual incidents and, really increasing our threshold for undertaking change based on one individual thing that's occurred, and whether we need to be looking at, I mentioned, looking at things as themes rather than individual incidents. We don't make changes to our medical systems in other ways, based on one individual case. So potentially changing our system too much can be based on one individual incident, I think has been a problem. So I think maybe we need to embed some of that research thinking, in terms that is obviously in this group. I also think that we need to be testing recommendations a hell of a lot more, and that's something that using quality improvement, implementation science, all those sorts of techniques. It's completely neglected though in this area. It's just not done.
We could have a long conversation about that, couldn't we, Richard and Peter? So thank you for kicking that off and helping out with our thinking. If people do need to leave, we are over the allotted time. Peter, would you mind answering one more question before you have your cocoa and head off to bed? Is that okay? Mike has a question he would like to ask, if that's okay. Mike, over to you.
Thanks, Rebecca. And thanks very much, Peter, for a really interesting talk. I absolutely agree with your last point. Can you hear me okay? Sorry, I'm on. Yeah, I absolutely agree with the final points you made around the need for the next step side of things. I think we've got really good at describing problems in healthcare systems, and those next stages I think are absolutely key. I'm an intensive care doctor by background, and the clinical team involvement in this I think is really key, particularly from a knowledge mobilization and sustainability point of view. One of the things that we've been posed in some of the reviews that we do in hospital, and I think this is a very valid question from particularly patients and relatives themselves, is when an investigation has gone on, they want to know when we knew the basis on which we've come back to them, the findings of the investigation. And often our investigations have taken, maybe 6 months, maybe a year, but we had those initial insights on day one. We knew immediately that this was the contributory factor, this was the causative nature of things. How do we bridge that gap between, because rightly we've had a face back to us to say, so you knew this on day one, this is now 6 months later, what have you done about it? And very often it's been through a whole process, and we're only then beginning to take some of those actionable insights forward. So what do you think we need to do as a system to start broaching that really difficult timeline between, yes, this is an interesting thing we have to get valid insights from, but equally we're answerable to our patients and relatives around about how we do the right thing and learn from it?
Yeah. It is a tricky question, isn't it, about the robustness? And it probably gets back to the previous question too, about that threshold for, when we are taking action. Some of the services, and I'm sure this is happening in the UK, are doing debriefs with their staff straight after the incident, and they're calling them huddles, and there's various names for them, but are essentially doing a focus groupy kind of process. They're trying to make it a safe space, for people to speak up at that point. And they're gathering information at that time. And part of that process is intended as to try and facilitate some actions that are low risk in terms of change, and obvious in terms of things that need to be done. One's got to be really careful about that in healthcare, don't they? So what can be quite obvious is often more complex than what you can think. But that may be part of the solution. But I think some of the direction that you're going in the UK, I think is part of this as well, in that I think we're just spending too much time on your words, defining the problem, and not enough time on solution generation, solution testing, and thinking about this not just in terms of what's happened for this particular patient in that intensive care unit, but what are the three big factors in that intensive care unit that we can get best bang for our buck if we put in larger scale interventions. And I think maybe you're trying to think about that a bit better than us in the UK. Gee, it's hard though. So, but I think that's the direction we need to go. It's an easy statement to make. It's much harder to do it in the real world.
Yeah, thank you.
I think we'll finish on that note. It's hard, but there is hope. Thank you very much again, Peter, for coming along and presenting to us today. And we really look forward to seeing you at the end of this 4 years. It's a really exciting piece of work, and it was a great presentation. Thank you.
Thanks, Rebecca, and thanks to Will. Thanks to everyone, and really enjoyed your questions, and look forward to catching up. Thank you.
Bye, everyone.